Hello, my name is Victoria and I will be doing a literature review on pelvic inflammatory diseases. So to introduce pelvic inflammatory disease, what is it? It's an inflammatory infection that affects the reproductive system. It affects the upper genital tract, including the uterus, fallopian tubes, ovaries, and sometimes the pelvic peritoneum. It is mostly commonly caused by the bacteria or ascending sexually transmitted infections, which are particularly chlamydia and gonorrhea. And then also pelvic inflammatory disease, which is abbreviated as PID. It basically remains a major cause of preventable infertility and ectopic pregnancies. So early treatment with antibiotics is essential to prevent damage to reproductive organs and also to prevent infertility or a future ectopic pregnancy. So by the end of this presentation, I will explain the detailed pathophysiology of PID, discuss the evaluation of PID, explore and identify differential diagnosis of PID, identify the common clinical presentations, red flags, and immediate actions to take, apply structured diagnostic reasoning, management and treatment goals, discuss and compare research guidelines of PID, review patient education, follow-up and referral criteria, and protocols regarding PID. So to better understand PID, let's go through the pathophysiology. PID begins as an ascending infection from the cervix into the endometrium, fallopian tubes, ovaries, and occasionally the peritoneum. Chlamydia and gonorrhea disrupt cervical defenses, allowing pathogens to ascend. PID is a disease that is often polymicrobial, including anaerobes and organisms associated with bacterial vaginosis. At the cellular level, chlamydia invades epithelial cells and replicates intracellularly, causing cell rupture and scarring. And gonorrhea produces toxins that damage the tubule mucosa. So the loss of ciliated epithelial cells impairs ovum transport, and this explains the pathophysiological basis of infertility and ectopic pregnancy. The inflammatory cascade leads to edema, fibrosis, adhesions, and potentially even tubeo-ovarian abscess formation, which I will also throughout this PowerPoint abbreviate as TOA. So here are some common presenting symptoms of PID. The most common one is bilateral lower abdominal or pelvic pain, but then some other frequent symptoms include abnormal and purulent vaginal discharge, dysuria, dyspareunia, fever or chills, intermenstrual or postcoital bleeding, and then also on examination, some cervical motion tenderness, uterine tenderness, and adnexal tenderness are classic findings. So pain may also worsen during or after menstruation due to decreased cervical mucus protection during that time. And then also the pain of PID may worsen with some walking, jumping, intercourse, or other activities involving movement. And then on bottom left, there's just some other key symptoms associated with PID, which are similar to the ones I just went over. Now, how do we approach the patient? So for sexually active women presenting with pelvic pain, PID must remain high on the differential diagnosis list. The first priority is ruling out ectopic pregnancy. So what we would do is get a pregnancy test, which would be mandatory. And then next, after that, a focused sexual history should assess for STI exposure, prior PID, contraceptive use, and timing of the symptoms. This pelvic exam that we would do should assess for cervical motion tenderness, adnexal tenderness, and uterine tenderness. Some CDC guidelines emphasize that treatment should not be delayed while awaiting test results, and clinical suspicion is sufficient to initiate empiric treatment and therapy, so make sure we start the patient on antibiotics right away. And then there are also some other references on the bottom left slide. Here are some potential differential diagnoses. So the first one is acute appendicitis, and acute appendicitis may present similarly, but it's often localized to the right lower quadrant. So ask where the pain is specifically. Is it only on the right side, or is it bilaterally? Next differential is a UTI, ruptured ovarian cyst, and then ectopic pregnancy. So ectopic pregnancy is particularly dangerous and must be excluded immediately. Next down the list is endometriosis, adnexal torsion, and then also torsions often do present with sudden severe unilateral pain, so once again ask about pain symptoms. Next is diverticular disease, irritable bowel syndrome, septic abortion, and traumatic injury. And once again, references to the bottom left, Casanova, Domino, Jenkin and Vedeket and Ross. So here are some red flags. So the first one is a surgical emergency like appendicitis cannot be excluded. Ask the patient if they're pregnant. And then, has the patient been responding to clinical oral antimicrobial therapy or not? If the patient is unable to follow or tolerate an outpatient oral regimen, that's also a red flag. And then if the patient has a severe illness, severe abdominal pain, nausea and vomiting, or a high fever. And then of course, if the patient has a TOA. So now we will go through the actions. Here are some immediate, urgent actions and also non-urgent ones. So we'll go ahead and start with the immediate ones. We want to evaluate for an abscess. We want to do a pregnancy test to ensure the patient is not pregnant. Do STI testing, which includes gonorrhea and chlamydia, HIV and syphilis. And of course, right away, we want to put this patient on empiric broad-spectrum antibiotics. Now, some non-urgent actions we could do is notify the partner and treat them as well, because we don't want the patient to be exposed to the bacteria back again and sharing it back and forth. And then educate the patient and the partner about STI prevention and contraceptive use. We need to go over the patient's history and physical. So for the comprehensive history, we will discuss with the patient their sexual history. If they're using contraception, we want to make sure they are not exposed to STIs. So once again, that kind of correlates with the contraceptive use. And if they have any partners that have STIs, we want to ask them if they have any history of PID, and then ask them about their pelvic pain, have an assessment, see if it's unilateral, bilateral, lower, upper, where it's located, and then also ask about their menstrual history and bleeding. Ask if their menstrual cycles are regular, if they have bleeding in between their menstrual cycles, so just double checking on that. And then for their pelvic examination, we want to make sure that we examine their abdomen, their pelvis, and then also just assess for any masses, and any masses that would be a TOA as well. So here are some diagnostics. This includes some patient history, a physical examination, completing that pregnancy test, an ultrasound if an abscess is suspected, and then a nucleic acid amplification test, which is abbreviated as NAAT for chlamydia and gonorrhea. And then some lab work we could do would be a CBC, ESR, and a CRP. And then references bottom left of CDC, Rogers, and Ross. So some management and treatment goals that we have for a patient that has PID would be rapid infection control, and then prevention of infertility and ectopic pregnancy. And we want to reduce that chronic pelvic pain. The focus of inpatient management is high-dose IV antibiotic therapy with an antimicrobial spectrum that covers both aerobic and anaerobic organisms. And in the case of the patient having TOA that does not respond to antibiotics, the next steps would be surgical drainage or even hysterectomy. And that really just depends on the reproductive state and the desires of the patient, what they have in mind. We want to manage this as rupture of a TOA with septic shock is a life-threatening complication, with mortality rate being approximately 10%. So if there is a rupture, it must be treated surgically. And that is from references Casanova and CDC. More than 24 hours of inpatient monitoring is advised for women with TOA. Here are listed different treatment options for the patients. So once parenteral regimen medication achieves clinical improvement for this patient, we would switch over to oral therapy, and that would be like containing 100 milligrams of doxycycline taken twice a day. 500 milligrams of metronidazole twice daily is also advised, and we want them to complete 14 days of antimicrobial therapy. Here is some research of PID treatment options. As you can see, it lists the CDC and then the CNGOF and SPILF, which is a French guideline, and then also some European guidelines. So we'll start with the CDC, which is the US guidelines. The outpatient empiric therapy for mild to moderate PID uses a combination of oral and parenteral agents. It includes a ceftriaxone plus doxycycline with or without metronidazole. And then there's some alternative regimens that include the cefoxitin with doxycycline, once again with or without metronidazole, and then Also, azithromycin or fluoroquinolones can be considered for alternative regimen options. Now, the CDC treatment is typically 14 days of antibiotics with also decision on metronidazole. Now, the CNGOF and SPILF French guidelines recommend, they're really all similar, but they recommend ceftriaxone plus doxycycline and metronidazole or fluoroquinolones with or without ceftriaxone. Now, the French guidelines do differ from the CDC US guidelines in the duration of antibiotic therapy. So instead of the 14 days, theirs is approximately 10 days of treatment. Now, European guidelines, they're really similar to the US and the French ones, and it does mirror the US recommendation of CDC of typically 14 days of treatment, and then their just version is a little bit more condensed of what they require. And you can see that as listed on the slides on the left and right. Left is the outpatient regimens, right is the inpatient regimens. And I got this information from Yusuf and Trent. So here is a study that I had found from Roster and also from Workowski et al. And according to recent research, the amount of PID cases that attribute to chlamydia and gonorrhea is decreasing, and approximately 50% of women who have been diagnosed with acute PID do test positive for either of these two organisms of the chlamydia gonorrhea. So following more than 10 years of rise, gonorrhea rates in the United States have decreased in 2022 and 2023, and then cases per 100,000 population are decreased from 214 in 2021 down to 179.5 in 2023 as shown in the graph on the bottom left. Now, the prevalence of chlamydia stayed steady for a number of years with a rate of 492.2 cases per 100,000 people in 2023. So here is some patient education. We want to educate the patient on the importance of completing the whole antibiotic regimen, even if they are feeling better, to avoid resistance and recurrence of infection. We want them abstaining from intercourse until they and their partner finish the whole entire course of antibiotic treatment, because we do not want them to share the disease back and forth. Now, if the patient does have PID, we want them to notify their recent sex partners so they can get treated as well. And recent sex partners are those that they have had sex with within the last 2 months before their symptoms had started. So we just want to make sure we let them know, hey, notify your partners within the last 2 months before these symptoms started. And if their sex partners are not treated, they can infect you again. So we just want to let them know. We want to make sure whoever they're currently having sex with, they can share it back and forth. We want them to both get treated. And then we want to educate on preventing PID by them using a latex condom during intercourse, and then also refraining from sex with a partner who does have symptoms of the infection. We want to let the patient know that PID can cause scars to form on the fallopian tubes, so if the patient is trying to get pregnant, they might have a higher chance of having an ectopic pregnancy. Let them know an ectopic pregnancy is a major cause of maternal mortality. We want to let the patient know to also notify the provider if they still have symptoms after getting antibiotic treatment, if their symptoms go away but then they come back, or if they have new pain or other symptoms as well. So for testing, have at minimum annual screening for chlamydia and gonorrhea if sexually active, basically at the age of 25 years old or younger. Now, if the patient is older than 25 years old, we want them to get tested every time they have a new sexual partner, and then also if they have more than one sexual partner or a partner with a diagnosed STI. And then I attached a link for PID patient education pamphlet that could be handed out to the patient and their partner. So for follow-up, women receiving treatment should have a follow-up and be reevaluated by their care provider in 3 days after starting antibiotics, just to ensure that they are taking their antibiotics properly and that the treatment is effective. Since there should be clinical improvement of decreased abdominal pain and tenderness in 3 days or less after treatment regimen is initiated. Women who have received a diagnosis of chlamydia or gonococcal PID should be retested in 3 months after treatment, regardless of whether their sex partners have been treated. Now, say the patient says, hey, I can't come in 3 months. Tell them, come in whenever you're able to, but make sure you come in for retesting within a 12-month period after the treatment. We do not want them waiting longer than 12 months. The sooner, the better within that 3-month time frame. A specialist referral or hospitalization is indicated for those that have a failure to outpatient oral therapy, if there's suspected or confirmed TOA that may need surgical intervention, if they have a severe illness that includes a fever and or vomiting, and if they are pregnant, as noted by CDC and Domino. In conclusion, PID is an ascending infection with significant reproductive consequences. The most common presentation is bilateral lower abdominal or pelvic pain. Now, some other symptoms include dysuria, dyspareunia, fever, nausea, vomiting, some cervical motion tenderness, uterine tenderness, or adnexal tenderness. For diagnostics of PID, that includes an NAAT, a pregnancy test, labs of CBC, ESR, and a CRP, and ultrasound if an abscess is suspected. We want to educate the patient to complete whole course of antibiotic regimen, to educate on abstaining from intercourse until they finish the whole entire course of antibiotics, and also we want to ensure their partner is getting treated as well. So, to reduce some long-term morbidity, we want to do early clinical recognition of PID, do evidence-based antibiotic therapy, and structured follow-up of reassessing the patient in 3 days after they start their antibiotics, and then also again to retest for chlamydia and gonorrhea in 3 months after treatment, or once again, if they can't do the 3 months, to at least come in before 12-month time period after treatment. And here is a list of my references. Thank you for listening.